So, good evening, everyone who has joined here, my seniors, my colleagues, and my juniors. With this, I would like to start our case box webinar with the theme of dementia. We have frontotemporal dementia as the subject is on this sixth webinar. I would like to invite my co-chairperson, Dr. Nihal, for conducting this sixth webinar ahead and start. Please introduce our first chairperson for the evening.
Our first chairperson is our dear psychiatrist from Telangana. He is Dr. Vishal Akula, sir. Vishal Akula, sir, is a consultant psychiatrist and the director of Indoor Neuropsychiatric Hospital, Nizamabad, and also the professor and HOD of Govt Medical College, Jagtial in Telangana. Sir is currently the National Direct Council member of IPS and also the Honorable General Secretary of IPS Telangana State Branch. Apart from the Psychiatric Society activity, Sir is active in the IMA wing as well. Sir is currently the state working committee member of IMA Telangana and also the vice president of his own Nizamabad branch. Sir has won many national awards such as the President Appreciation Award for the year 2019 as Best Secretary for overall performance in national level of IMA and IMA Ketan Desai National Leadership Award from Government of India, Niti Yogi Ayog Chairman Dr. V.K. Paul on 14 November in New Delhi. Sir also has received Dr. N. Ramchandramurthy, a Best Research Award in Psychiatry from National President Dr. Jailal and Patna on the occasion of National Indian Medical Association Conference in Patna. We welcome you to the webinar, sir. Sir, please unmute, sir.
Thank you, Nihal, for your kind words. And first of all, I would like to appreciate Young Psychiatry Subcommittee team, chairperson, co-chairperson, and convener. And first of all, I would like to thank you all for giving this opportunity.
Please. So we'd like to request you to introduce our speaker one for the day.
It's my privilege to introduce first speaker of today's webinar, Dr. Susmita Sarkar. She is a consultant psychiatrist at Neuromax Healthcare Services, Kolkata. She did her MBBS from College of Medicine and Sagore Datta Hospital, West Bengal, and pursued her MD Psychiatry from AIMS Raipur. Though she did her masters from 2023, she has many awards to her credit. She won ICMR thesis grant in psychiatry for November session 2021. She is also winner of West Zone Torrent Young Scholar Award. She won first prize in poster presentation in the first annual state conference of Chhattisgarh Psychiatric Society. So I request the speaker to present her case. Thank you.
Thank you, sir, for your kind words. Good evening, everyone. Today, I am going to present a case of behavioral variant of frontotemporal dementia. My screen is visible?
Yes, it is visible. You can go ahead.
Yeah. So this is the patient. The patient is 65-year-old male belonging to a Hindu middle socioeconomic status, and the informants are patient himself, patient wife, past medical records. Information is reliable and adequate. They came with the chief complaint of low mood, social withdrawal, insomnia for the last 4 years, occasional irritability for the last 2 years. Onset of the symptom was insidious, course was continuous and progressive in nature. Precipitating factor, nothing significant was found. So hereby, I will discuss the case in brief history. Due to the time constraint, I won't be going much detail of the history. I have the history. So anyone having any doubt can ask me. Patient was apparently well 4 years back till his retirement in 2017. He started having complaint of low mood. He was not feeling interested in any activity like before. He appeared to be dull. Along with that, family members noticed him to be withdrawn, less interaction with family members and others. He was also having occasional restlessness associated with palpitation, sweating, feeling of impending doom, lasting for 10 to 20 minutes, suggestive of panic attacks. Initially, he was taken to general physician, and surprisingly, he was prescribed inhaler and antibiotic, thinking that is of respiratory origin. But thing doesn't resolve, and then he was taken to psychiatrist one after the another. But significant improvement, there was no significant improvement. I'll be discussing detail in the treatment history. He started having difficulty in onset of sleep, in maintenance phase, in onset and early morning awakening was there. And for the last 2 years, new set of symptoms appeared, like he started becoming more irritable on minor issues, occasional anger outburst with or without any provocation. His social withdrawal, apathy continued. He was taken to another psychiatrist, and after 3 months of treatment with this medication and CBT, the patient stopped taking medication as there was no significant improvement. Stopping all this medication made the numbness go away, and initially patient was well. Then the symptoms of restlessness and weakness and panic attack cleared up within few months. He was taken to a tertiary care hospital of psychiatry and was admitted there. Detailed evaluation was conducted and he was prescribed tablet aripiprazole, which was hiked up to 20 milligram, and vortioxetine up to 20 milligram. Due to some personal issue, patient could not stay here long, and he was released after 2 weeks. He was directed to do a CT brain from a local hospital, and which was reported normal. He continued to go to hospital every 2 months for next 1 year, but he didn't feel well. Then the corona pandemic started and he could not go back to the hospital, and he continued meds for few months and then stopped. Then he started seeing another psychiatrist, and he was given tablet dosalpine 75 milligram and duloxetine 30 milligram. With that, there was no significant improvement, but patient had severe constipation with that. To mention that patient had to admitted in surgery ward for the surgical evacuation of the stool. And along with all this symptom, patient started showing aggressive behavior on and off. The patient came to us in the year 2022 with the symptoms of recurrent low mood, apathy, social withdrawal, and irritability. Coming to the negative history, there is no history suggestive of altered sensorium, clouding of consciousness suggestive of delirium. There is no history suggestive of significant impairment of memory. There is no history of any tremor, abnormal body posture, marked slowness in activity. There is no history of significant head injury, loss of consciousness, seizure. There is no history suggestive of cerebrovascular accident. There is no history of any substance use. There is no history of hot and cold intolerance. No history suggestive of firm fixed belief of being controlled by any external agency. No history of unconsciousness, non-recognizing family members. There is no history of persistently elevated mood, interest, talkativeness, tall claims, elevated self-esteem, new plans, and over-familiarity. No complaint of repetitive intrusive thoughts, acts, or impulses. No history of muttering to self. No history of mutism, posturing, staring, suggestive of catatonic feature. Coming to the past history, his past history was quite significant because 20 years back, when he was around 40 to 45 year of age, there was history suggestive of major depressive disorder with psychotic symptoms, and he was prescribed tablet olanzapine and risperidone. We didn't get the complete medical record from the patient, and according to the patient and family member, after he continued medication for 1 month, and after 1 month there was a history of suicidal attempt by hanging, which was moderate to severe lethality with strong intent. Stop the medication, and then there was spontaneous resolution of this episode by 3 months. This is the treatment history. As we can say, in the year 2017, he was prescribed tablet escitalopram 10 milligram and clonazepam 0.5 5 milligram, and it continued for 1 year with no significant improvement. And then sertraline, tonazepam, and olanzapine, it was for 2 months, and there was no significant improvement. In 2021, tablet dosalpine and duloxetine 30 milligram along with CBT for 3 months, but improvement was minimal, but side effects severe constipation, as I mentioned. And from tertiary healthcare center, he was prescribed tablet aripiprazole 20 milligram and vortioxetine 20 milligram, as I mentioned in the HOPI. And there was numbness with that medication, but no such improvement seen. Medical history, no history of significant medical illness like hypertension, diabetes, and no, not in any regular medication except that of psychiatric medication. His family history was also quite significant. He born of non-consensual marriage, first in the birth order of 3 siblings. Father had history suggestive of alcohol dependence syndrome, and he died by suicide at the age of 63 years. Mother died of ovarian carcinoma, and younger sister died by suicide at the age of 20. There is history of multiple cancer in the maternal side, like history of pancreatic carcinoma in the maternal uncle and breast carcinoma in the maternal aunt. Coming to the personal history, birth and developmental history, antenatal, natal, postnatal, developmental, and childhood history was not forthcoming. Scholastic history, as per patient, his performance was below average and he completed his graduation. Substance history, there is occasional cigarette intake but not in dependence pattern. Coming to the pre-morbid personality, social relation, cordial, patient took part in family function, had friends, intellectual activities and hobbies, nothing specific, mood dysthymic, quality of mood, generally sad, character, attitude towards work and responsibility. Patient was responsible towards work, and he was very particular about his duties, rules, and responsibility. And he was quite finicky about the little details and all the activities. Interpersonal relationship and adaptability, had difficulty in adapting and expressing. Interaction with family and friends was normal. Standard in moral, religious, social, and humor was high. Energy, he was energetic but ill-sustained output. Fantasy, nothing significant. So my impression of his pre-morbid personality is obsessive traits. General physical examination, he was thin build, BMI within normal limit, and pallid uterus, cyanosis, clubbing, edema absent, vitals were within normal limit. Local examination was within normal limit. Systemic examination, respiratory system, cardiovascular system, GI system was within normal limit. In CNS examination, cranial nerve examination, all cranial nerve came found to be intact. There is no examination finding suggestive of any bulbar or any pseudobulbar palsy or any nystagmus. Sensory examination was within normal limit. In motor examination, power tone within normal limit. There is no sign of any upper motor or lower motor neuron disorder. Cerebellar function was also within normal limit. Coming to the mental status examination. Mental status examination was done in the year 2022 October, the day when patient first came. General appearance and behavior, the patient entered the room, sat on the stool assigned, and returned the greetings of the doctor. He was kempt and tidy. The eye contact was initiated but not maintained. The patient appeared to be disinterested to the interview. Rapport was established with some difficulty. Psychomotor activity was decreased. Speech was spontaneous, relevant, coherent, goal-directed. Decrease, but the amount of speech was decreased. The rate was decreased. Normal procedure was absent. There was monotonous speech. Subject, affect subjective. Patient said in Bengali, "Kharap lage" means patient doesn't feel good. Objective, depressed. Mood. There is decreased intensity, decreased range, but it was communicable, appropriate in nature. Thought form, there is no formal thought disorder. Stream, no abnormality. Content, there was ideas of hopelessness, helplessness, decreased self-confidence, passive death wishes, and in perception, no abnormality detected. Coming to the higher mental function, patient was alert, conscious, oriented to time, place, and person. Attention and concentration, digit forward and backward was done. Impression, aroused but not sustained. Memory, immediate, recent, and remote memory was intact. Intelligence was average. Abstract ability, he didn't participate for proverb and similarity, so could not comment. Judgment, test judgment was normal. Social and personal judgment impaired. MMSC done on the date of first examination, that is October 2022, and it came out to be 23/13. Mostly deficit was in the in attention domain, attention and concentration domain. Coming to the diagnostic formulation, index patient, 65-year-old male, belonging to a Hindu nuclear family of middle socioeconomic class from an urban background of Kolkata with obsessive personality trait, family history of completed suicide in father, younger brother, mother died of ovarian carcinoma, history of pancreatic carcinoma in maternal uncle and breast carcinoma in maternal aunt, with past history of major depressive episode with psychotic feature and a suicidal attempt of severe lethality and moderate intake in that episode, and spontaneous resolution in 3 months. Treatment history revealed failed trial of tablets sertraline, vortioxetine, dosalpine, duloxetine, brought by the family members with complaint of anxiety, loss of interest in activities, occasional aggressive behavior and anger outburst, passive death wishes for the last 4 years, with onset being insidious, course continuous and deteriorating, with MSC revealed poor eye contact, and the patient appeared to be disinterested to the interview. RAP was established with some difficulty, with decreased psychomotor activity and thought revealing ideas of hopelessness, helplessness, decreased self-confidence and passive death wishes. And cognitive function assessment showed impaired attention and concentration, semantic fluency affected with impaired personal judgment, and MRI brain showed bilateral symmetrical frontal lobe atrophy, which was significant. So my diagnosis as per ICD-11 is provisional diagnosis 6D83 frontotemporal dementia. So coming to the case conceptualization, we know that BVFTD, that is behavioral variant of frontotemporal dementia, doesn't follow the usual course of dementia, and it's very difficult to pick up initially, and it's basically difficult to distinguish from the non-degenerative type of primary psychiatric disorder from BVFTD, and studies shows that around 50 to 60% cases are missed and they are re-diagnosed as BVFTD after 5 to 6 years. And recent studies say that the emotional change, that is, emotion is a part of cognition, and the emotional changes that we are seeing here is a part of cognitive dysfunction only. So coming to the case conceptualization, see, here is the patient with recurrent depressive episode, impulsivity, aggressive in form of aggressive behavior, social withdrawal and apathy. He is in middle age group. There is mild cognitive decline in multiple domains and strong family history of psychiatric illness and non-communicable disease. And most importantly, onset is insidious and gradually progressive in nature and for the last 4 long years. So we suspect of, there is suspicion of neurodegeneration.
Meeting lo unna disturb. Meeting lo.
So we did serial cognitive function assessment, and in that we found that more than 2 domains of cognition is affected, and we know cognition defect in cognition is a hallmark of dementia. Then we went go for MRI brain structure for the structural evidence of the neurodegeneration, and we found bilateral symmetrical circumscribed atrophy in the frontal and temporal lobe. So we make possible diagnosis of behavioral variant frontotemporal dementia. Now I'm coming to the management proper. So detailed history, serial MSc, detailed neurological examination, cognitive function assessment were done. And we can see that treatment history, there is failed trial of tablets, sertraline, vortioxetine, dosalpine, and fluoxetine. So we started the patient on bupropion, matching the symptom profile, that is patient is having withdrawn behavior, apathy, anxiety, and we tried bupropion up to 300 milligram. Anxiety symptom decreased a bit, but not stop. As all the symptoms are not adequately controlled with tablet bupropion, tablet desvenlafaxine was added and hiked up to 200 milligram. With this, there is minimal anxiety symptoms, but apathy persisted. As apathy was persisting and patient is withdrawn, so tablet atomoxetine was started, and those adjustment was done according to the response and side effect profile. And at 40 milligram dose, patient was tolerating it well, and the apathy was decreased. Investigation were sent to rule out other reversible causes of dementia, and which came out within normal limit. Mental status examination and cognitive function revealed impairment in different cognitive domains with relatively intact memory function. There was impaired attention, concentration, and semantic fluency. MRI brain was advised, which revealed bilateral symmetrical circumscribed atrophy in frontal and temporal lobes, which was significant. Here is the MRI plate of that patient. Here we can see the atrophied areas. I have marked few areas. So significant atrophy in bilateral frontal and temporal lobes, here we can see. And in this we can see that hyperintensity frontal in frontal and temporal lobe and white matter hyperintensity. Here also we can see the ventricles are dilated, here prominent guy. So there is evidence of significant atrophy in the bilateral frontal and temporal lobe. So tablet memantine was added in view of dementia and titrated up to 20 milligram. At present, patient is maintaining well with tablet bupropion 300 milligram, tablet desvenlafaxine 200 milligram, and tablet memantine 20 milligram. Patient was asked for 3-month follow-up initially and then 6 monthly. As patient is tolerating the medication well and adequate symptom control is there, plan is to continue the same medication. And in non-pharmacological management, psychoeducation regarding the disease, course progression, importance of adherence to treatment was explained to the patient and their family members, issued related to caregiver burden addressed. So any query? Thank you.
It was a really enlightening talk on a difficult topic by Dr. Susmita Sarkar. I appreciate her work in bringing out a wonderful case in front of us today. She has meticulously documented the course of illness and various issues related to frontotemporal dementia. So frontotemporal dementia is one among dementias. It consists of an insidious onset of dementia completely overshadowed by personality and behavioral disturbances.
Any role in it?
I'm audible?
Yes, sir. Yes, sir. You're audible, sir.
So it consists of an insidious onset of dementia completely overshadowed by personality and behavioral disturbances. In majority of cases, frontotemporal dementia is misdiagnosed as a major depression, bipolar disorder, obsessive compulsive disorder, or other psychiatric illness. So it needs thorough evaluation to come to a correct diagnosis. With these few remarks, we'll go for queries regarding the case. Our speaker is ready to take the questions.
So please, you can ask the questions in the chat box, sir.
Nihal, can you help me?
Sure, sir, sure, sir. Okay, fine, I'll ask the question, sir. Sushmita,
Yes,
by
sir.
history, what were the telltale signs which made you think that these symptoms are because of organicity? As the history and minimal improvement could be very well explained by depression and inadequate rate of antidepressants.
Sir, neurodegeneration we thought of because when there is the telltale, first of all, we have to think when a patient of middle age group is coming us with any kind of emotional symptoms, and which is of like when we have to think, we have to differentiate between the non-degenerative type of primary psychiatric diagnosis to degenerative type, that is dementia and like depression or other thing. So when a patient of middle age group is coming, even the standard test book and other mention that we have to screen for, we have to look for the degenerative causes and other things before jumping into the thing that we are getting in the first picture. And here in this patient, we can see that, as you mentioned, that patient was not improving with the kind of doses, or the kind of doses that he was used was not adequate, but he has been taking this medication, but no significant improvement is there. So that is one hinter for that. Another hinter is that mild that I am just stressing on that this middle age group, this is not a young patient, and the onset, kind of onset, insidious onset, and the progressive nature for the 4 years. And in case of depression and other thing, we know there is there is concept of spontaneous resolution also, the kind of the continuation for the 4 years. And then we can like, when we are suspicious about that, and then we go for the higher mental functioning and cognitive functioning, then we can find out some mild cognitive decline in multiple domain, that is in this patient, attention, concentration. The problem with BVFTD, that the concept that we have with dementia, that a patient will have memory problem, but only very few patients will start with that memory problem. Initially, they will start with the emotional problem and other problem, and cognitive also, the minute domain, that is attention, mild difficulty. The memory part actually comes later. So if we are like, we are not vigilant enough, that then we have to catch the disease after 5 to 6 years to come. And this patient has strong family history of psychiatric illness, non-communicable disease, and there is previous history of major depressive disorder, suicidal attempts. So all this are hinted towards like that patient is having some serious issue in his brain, and that insidious onset and the nature for 4 years make me think of neurodegenerative causes rather than non-degenerative primary psychiatric disorder. And then I go for further assessment and MRI brain that helped me to find out. But yeah, of course, one MRI can't say anything. I have to have the baseline MRI. This MRI showing there is significant atrophy, but actually we don't know how much atrophy it was before. So that is another issue. But yeah.
Any reason for choosing memantine over donepezil?
Sir, no such reason per se, but memantine, like in my personal experience, patient like the side effect profile and the things work better in this. We have seen that patient had difficulty in like anticholinergic. We previously there was severe constipation and other side effect. Thinking of that, like I started the patient on memantine, not of donepezil, like considering the side effect profile of the patient. Hello.
Presence of frontal release signs in the examination?
No, sir. No frontal release signs.
Can't be the diagnosis FTD with past history of depressive disorder?
Yeah, it can be, but then I think we have to put it like that: frontotemporal behavioral variant, frontotemporal dementia, and recurrent depressive disorder. I think, like, if we count this as one and two, like past, we don't count as like. Sir, I'm not sure. Like, what do you suggest?
What is the role of atomoxetine in frontotemporal dementia?
Sir, actually, as of like what textbook says, that there is no such treatment for frontotemporal dementia, like as a disease, like which can suppress the disease progression and halt the disease pathology. Nothing is like that. So what we have to, but we can't sit idly. What we have to do, that we have to treat the patient symptom wise. What are the symptoms we are having, and symptomatically you have to treat the patient and to give better quality of life. So patient was having that adding that like atomoxetine non-stimulant drug, it will be activating for him. We tried bupropion, and then desvenlafaxine was added to cover the anxiety symptoms. But for the like patient was having withdrawn behavior, apathy. For the activating effect of this, we added atomoxetine, and it has like role in not direct role, that you won't find anything like atomoxetine and DVFTD, FDA approved, and other things that these are used. But all this medication that we have used as symptomatic, whatever symptom we have seen, and we tried to get into the symptom, and the patient is doing well.
Okay. What were the cognitive domains affected in this patient as per DSM-5?
As per DSM-5, cognitive domain that are affected in this patient is attention, concentration, then mild semantic fluency, that is in language but not much, and behavioral domain, that is the emotion as a part of cognition.
I think we can move to the next speaker before we can cover those questions later on.
Last
Yes, yes, sure, sir, sure, sir.
Can I know the use of aripiprazole in this case, as you have mentioned, 20 milligram was given. Can you justify?
Sir, I don't know why, because whatever I got from the history during that time period, patient was having more kind of depressive symptoms and some anxiety symptoms. But why he was prescribed aripiprazole at such high dose, so really I don't have idea. Aripiprazole can be used as an augmentation, but in augmentation we use usually 2.5 to 5 milligram dose, maximum 20 milligram dose for augmentation. Like they have used vortioxetine 20 milligram, I'm fine with that. But as per augmenting agent, I know that we can use 2.5 to 10, not up to 20 milligram range. Sir, I can't say like why 20 milligram.
Thank you.
Welcome.
I think we can move to the next. I think it's time to introduce our chairperson two, second chairperson. Let me share the screen. Our second chairperson is Dr. Surgery Commander Shirod K Mishra, sir. Sir is currently the professor and HOD of Mahatma Gandhi Institute of Medical Sciences, Sewagram, Wardha. Sir has around 60 sir has published around 60 articles and has been author of 5 book chapters. Sir has many awards and fellowships. Sir has been trained in child and adolescent mental health and aviation psychiatry. Sir has GC Borrell Award of Industrial Psychiatry, Dr. A.B. Datta and Dr. Inlaram Subbareddy Award of IAPP, SM Lula Oration Award of of Bombay Psychiatric Society, Dr. L.P. Shah Oration Award. Sir was also treasurer of IPS from 2020 to 2022. Sir was a direct council member of from 2015 to 2017. Sir was an EC member and treasurer of child and adolescent psychiatrist. Sir was an EC member of IASP, and Sir was zonal representative of Geriatric Mental Health Association.
Thank you, Nihal. That's enough, sir. Yeah.
We welcome you, sir.
Yeah, thank you very much, Nihal, Kashyapi, and the whole young brigade, and getting me here. And Susmita has actually really presented very well the case, which was not a typical presentation of behavioral abnormality in a case of FTD, because primarily patient presented with depressive symptoms, treated with multiple antidepressants, and we sometimes found the depressive symptoms as a predecessors in the dementia, and more so in case of frontotemporal dementia. So with this short brief, we have already had a lot of discussion. I'll take this opportunity to introduce Dr. Shaji sir, which has been an old friend for almost 2 decades. And since I was at Kochi long back, way back in 2000, and we have a lot of interactions. And instead of this formal introduction, I know Shaji sir, he has been the founder member of Indian National Geriatric Mental Health and past president of Indian National Geriatric Mental Health. His work in this, specifically in the geriatric mental health and in dementia, has been recognized internationally, and he has been presently working as one of the dean in the dean research in the Kerala University of Health Sciences, and he has got a lot of publications as I know, and his awards has been a lot of awards, and specifically in the National Academy of Medical Science, ICMR, and he has been a lot of work in this geriatric mental health, as he has been chairperson of geriatric mental health in several times in IPS subcommittees. And with this short introduction to Shaji sir, I'll request Shaji sir to just give a brief idea about the frontotemporal dementia and the major 4 variants, and among them the behavioral variant, which is the most common variant and the most difficult to diagnose in cases where the symptom profile may not be clear cut. So in this, I request Shaji sir to go for his presentation.
Thank you, sir. Thank you, Kishore. Nice meeting you after a long time.
Thank you, sir. Thank you.
As was mentioned by the chairperson, this case probably is not very common among, or this kind of presentation is not a very common presentation of frontotemporal dementias. I think this is worth emphasizing, that frontotemporal dementias, there are different types of frontotemporal dementias. So this case, as rightly mentioned by the chairperson, it's not the classic kind of FTD which we come across in clinical practice. This could be FTD too. So I'm quickly going through a round wherein this is once you are retired and senior, you take this liberty of saying what you want to say. I hope that is all right with the chairperson and others. And Nihal, I think I am audible enough.
Yes, sir. You're audible enough, sir.
Yeah. So quickly, if you sit in your consultation room and if someone comes, then we must know how to go about diagnosing dementia. Susmita diagnosed frontotemporal dementia. It's not that somebody else will diagnose dementia and send it over to you. No, you make that diagnosis. So first step is look for reversible causes. Though rare, they are out there. Especially if you are in a general hospital psychiatry unit, you will see many. Before I forget, I must also say that we had seen a frontotemporal meningioma presenting as classic frontotemporal dementia. So it's not that every clinical presentation which looks like a frontotemporal dementia has this kind of MRI finding which Susmita presented. It could be simply that a big meningioma sitting there, something like that, a tumor. See, once you rule out all causes for reversible, treatable, a list are there, I'm not going into details, then see whether the dementia syndrome can be explained by cerebrovascular disease. So that is an exercise which you will go through. That is step number 2. Then, if vascular dementia is there, then you call it vascular dementia or mixed dementia. We will not get into that mixed dementia here. So if there is predominant cerebrovascular disease and characteristics, dementia syndrome is there, then you call it vascular dementia. So if that can be safely excluded, categorically excluded to a great extent, so no reversible cause, no cerebrovascular disease, then you are left with a number of possibilities which cause dementia as a syndrome, and this is a neurodegenerative dementia then. How common is this? About 50% of people who has dementia might be suffering from neurodegenerative dementia, around that or less vascular. It might depend on the geographical area. Sometimes vascular can be more in some place. Now, we must answer this question, every clinician. After you rule out reversible causes, after you make sure that this is not vascular dementia, does it really matter whether it is some kind of a particular type of neurodegenerative dementia or not? The focus of this presentation, and I'm sure this case, is that it does matter. It has implications for management. So these are the main things. I would request every aspiring young psychiatrist to be very thorough with the features of Alzheimer's disease, dementia with Lewy bodies, and frontotemporal dementia and other dementias. Because 87, when we passed, or some of us passed MD, we were quite happy to call many things organic brain syndrome and then dementia and send them over to neurology people. So that is not the case in India and globally. So we need to have the skills to diagnose or to differentiate different kinds of neurodegenerative dementia from each other. At this point, let me make it very clear that this differentiation can be problematic or rather difficult in moderate or severe dementia. But then it's much easier clinically when the person with neurodegenerative dementia is in mild or moderate stage. A diagnosis of frontotemporal dementia, if I am diagnosed with that, that has got implications for my family. Same thing if my diagnosis is Alzheimer's disease or dementia with Lewy bodies. Then the kind of behavioral problems which you might have is different. I stand corrected if I make statements which are not evidence informed. To the best of my knowledge, and it is my impression that some of these drugs which are used for certain types of neurodegenerative dementias are not helpful. We'll come to that. And the use of antipsychotics in dementia is a thing which we have to take a lot of care. And the risk of producing very adverse side effects in certain types of neurodegenerative dementias are a matter of concern. And prognosis, or rather course and prognosis, might be different from early Alzheimer's disease versus late onset Alzheimer's disease versus frontotemporal dementia, which usually has an early onset, and dementia with Lewy bodies and other dementias. This is very important point. It's not that Susmita mentioned this, that this patient was diagnosed as depression earlier. This is quite common. Dementia with, there are two mistakes which are usually made. This is not a problem with India or a problem with a particular institute. This is a global problem. And we must also recognize that we are learning more and more about neurodegenerative dementias, and we never knew this much before. So dementia with Lewy bodies and FTD can be misdiagnosed as AD. That's a very common mistake. Much more common than other mistakes. Then frontotemporal dementias can be misdiagnosed as psychiatric disorders. That is what I think happened here. It can happen to anyone. I had the privilege, or what shall I say, both me and Dr. Arun Kishore, who was, I'm sure Misraji knows him, we had diagnosed somebody as affective disorder. And 4 years later, we had no doubt in calling the person as frontotemporal dementia. So it happens. You yourself can do it, and we become wiser when more classical symptoms emerge. So that is nobody's fault. Quickly, I must say this, though topic is FTD, we must, it's my impression that most of us who are trained in psychiatry tertiary care centers may not be seeing enough number of dementias in general and Lewy body dementias in particular. I happen to know more about this because we run dementia clinics, and we see at least 20 patients of dementia on a monthly clinic every year for more than 20 years now. So dementia with Lewy bodies can be eminently diagnosed. Again, it's very common that dementia with Lewy bodies will be considered as Alzheimer's disease for some time. Usually, not always, it has got a much more rapid progression and psychotic symptoms. We have seen many cases where visual hallucinations, very well formed visual hallucinations are there in dementia with Lewy bodies. And then the tendency, either you yourself or somebody else will put people on antipsychotics for that, and they can have what is known as neuroleptic sensitivity. I recall in the early 90s, I had put somebody on small dose of haloperidol, and that patient had neuroleptic sensitivity following a series of falls and things like that. So it can actually damage and shorten lives. Not going into details, but then remember, unlike FTD, dementia with Lewy bodies is known to have fluctuating cognition. For example, we have seen patients, when we were following up many patients, we had seen them very disturbed, almost like delirium superimposed on dementia for a week, then becomes completely all right. You suspect whether what you saw was real. Then spontaneous Parkinsonism. That's very important thing to recall. You can have Parkinsonism in Alzheimer's disease. You can have Parkinsonism in dementia with Lewy bodies, and also in frontotemporal dementia. But then generally, spontaneous Parkinsonism, a Parkinsonism which has got early onset, more progressive, more earlier in onset than cognitive and behavioral symptoms, is very characteristic of one, dementia with Lewy bodies, two, dementia which happens in people with Parkinson's disease. Remember, Parkinsonism can happen in frontotemporal dementia, but that is usually late in onset. And in Alzheimer's disease, it's rather later. We said this. Remember here that cholinesterase inhibitors are much more useful, probably, in dementia with Lewy bodies than even in Alzheimer's disease. And risk of falls is something which is a major problem with dementia with Lewy bodies. Now coming to frontotemporal dementias, I am also very candid in expressing certain difference in opinion regarding the management of the earlier case also here. Rare if you take dementias of late onset. But if you take early onset dementias, the most frequent neurodegenerative dementia of early onset is early onset Alzheimer's disease. Almost same number or lesser number would be frontotemporal dementias. A family history will be a clue. And clinically it is distinct. And it has got a very slow, insidious onset, like in this case. Very slow. It progresses for years, months without any cognitive symptoms which are noticeable. And it runs a very long course. Usually happens in a physically fit person otherwise. These are the other features not present in all cases. Definitely was not there in this case, which was presented by Susmita. But then remember, when we are talking about frontotemporal dementias, we are referring to many subtypes of frontotemporal dementias also. These are criteria which were, tremendous work happened in the early 90s to define this. What is characteristic is that behavior disorder, which was not very prominent in the case presented here, whereas affective symptoms were very prominent here. Speech disorder, we have had many people who has a speech problem, predominant language problem. They may be fluent, but then they may be using a set of words and sentences more frequently. We will not discuss that in great detail. But then disturbance in spatial orientation, receptive speech and praxis is late in onset. Age of onset, family history, sometimes more presence of motor neuron disease could point more towards FTD. This is, to me, as was mentioned by the chairperson, this is not the, if you see 10 or 20 frontotemporal dementias in your clinical practice, then this patient which was presented would be, one or two like that. The rest will be different. And early significant change in personality is the hallmark, usually. Then there will be some language disturbance coming on in the first few years. Functional impairment will be there. Gradual onset of decline in functioning. And another thing, if you compare AD versus FTD, then in Alzheimer's disease, you have early memory problem, whereas memory problems can be very late, as in this case. Visuospatial disturbance can be late. Calculation problems can be late in onset when compared to AD. Naming difficulty can be late. Word finding, see, when it comes to speech, you have word finding difficulty, poor speech comprehension in Alzheimer's disease. I'm not saying that every AD is like this. Whereas stereotyped, I still recall a person who was a pensioner. He will, every visit, he will talk about how he went to the treasury to get his pension. And it was a very stereotyped set of sentences he will keep repeating in every interview. Sometimes we have seen progressive aphasia, person becoming very mute. And of course, we saw the MRI, how it looks like. So what is predominant and very unique about most cases, most types of frontotemporal dementia is their social behavior and their change in personality. The first case, if I recall, the first case I had been involved in diagnosis of frontotemporal dementia was when I was a faculty member in CMC Vellore, where we had this a man in the early 50s, before his retirement, having occasional binges of alcohol as well as a behavioral disorder unrelated to his alcoholism. And that person we could diagnose as frontotemporal dementia. This is in the early 90s. He did not have insight, but he never fought with the suggestion that he has a problem. But one of the hallmarks of early onset dementias in general and frontotemporal dementia in particular is early loss of insight. We have had any number of patients, and almost all of them had no insight, and that loss of insight is very early and very remarkable in the course of the illness. So it is just not possible to get them to comply to treatment. And motor activity, if time permits, I'll stress on that. No, this is just, this person has got nothing to do with dementia. I just, as I was preparing and thinking about this talk, I was reminded of one lady. She was in her 50s and she, from an upper middle class background, decided to carry a big jackfruit on her head, which was very socially inappropriate for her social background, and entered a private bus, saying that she wants to carry this as a gift for her son-in-law, which is very, very unacceptable socially. You know, it's a very inappropriate behavior. So the whole family was shocked because she got into the bus and then was unable to tell the bus conductor that she should get down in a certain place because she had this difficulty with language also. So they were thinking that she's getting aged, but then this kind of inappropriate behavior, impulsive, they never thought it will happen. So I think socially inappropriate behavior is a hallmark of dementia. And when such a major incident happens, that is the time when people start suspecting a psychiatric problem. And that is when a psychiatrist is consulted. So we must remember that someone for the first time having some socially inappropriate behavior, which is grossly inappropriate, then one has to really keep this in our back of mind as a possibility, because it's very easy, it's very tempting to make a diagnosis of, say, hypomania here, for example. Another person, we had a professional, actually he was a lawyer. His main presenting feature was that he will not change his clothes, mostly underclothes. Or he over 6 months to 1 year, he was happy with the clothes which he had been repeatedly wearing. He almost refused, and he wears, after his bath, he goes back to the clothes which he was wearing, and he was absolutely not disturbed about that, not bothered. So this can be a very, very important thing. And wandering can be a big problem, and he had that quite a bit. And inappropriate behavior. In fact, when I went to the court premises to buy some court fee stamp, he came running all the way, shouting loudly my name and then calling out, and everybody else looked very perplexed, because that's not something which a lawyer will do in a court premise when he sees someone who is rude to them. And yet another, just to highlight this nature, we had obviously he had frontotemporal kind of dementia syndrome, not a really degenerative kind. He had a encephalitis, he had lesions of frontotemporal region of the brain, and then he had characteristics which are described in frontotemporal dementia. When he goes to shops, when he sees toys for his grandchildren, he will quietly take them without the knowledge of. I mean, in this, he was living in a rural area, but then when it came to the notice of the shopkeepers, they were wondering what to do with him, because he was quietly shoplifting. And few occasions, this the sales girls who were there, he will tell them things in a very quiet manner that we should meet up and we should have good time and things like that. It was very embarrassing for the relatives. They couldn't even believe that he will steal things. He will make such statements, because otherwise he was quite preserved. And again, if everybody could mute, that would be great help. And this person whom I was referring to, actually he was known to me. He had this tendency of getting into a bus which goes up to Guruvayur temple. He will sit in the bus. He will not get down anywhere. He will go to Guruvayur, sit in the same place and come back. He wants to do sightseeing, it seems. So he had a tendency to, whenever he has free time, he gets into a private bus, goes to the destination, comes back to his place. So it was pointed out to him, but he did not have insight. He was getting irritable, because if I want to have sightseeing, I'll have sightseeing. Who are you to? So it can be very difficult. And most people with pre-senile onset frontotemporal dementia will be fairly well built, and when it is not possible to, with lack of insight, it's almost impossible to get them to behave socially and appropriately. So this is the difference of opinion with presenters and many people. I know that there is this force of habit, but to the best of my knowledge, and I hold that view, that we have mild to moderate dementia of Alzheimer's type, which will benefit from cholinesterase inhibitors or other similar drugs. Maybe severe dementia, donepezil, Alzheimer's. And the useful and dementia with Lewy bodies may even respond better, because they have very severe cholinergic deficiency than Alzheimer's disease. So you can give cholinesterase inhibitors to both AD and LBD, but definitely not to people with frontotemporal dementia. I want to make this point. If there is evidence against what I say, I will be happy to receive that and correct mine. And force of habit. Now, there was this early period where, as Dr. Mishra was saying, that we started Alzheimer's Society in Kerala. We had this rivastigmine was the first drug to be launched. And there was this person who apparently we discovered after a few months of putting him on rivastigmine. That is the first patient I put on rivastigmine. He was having actually frontotemporal dementia. Late onset, of course. He did not benefit. So there is very limited or no literature which categorically makes us believe that you can give cholinesterase inhibitors in frontotemporal dementias. You ask me, do people give? Yes, physicians and neurologists, they give. It's like they give antidepressants. I'm sure many antidepressant escitalopram will be prescribed by physicians and neurologists. The argument there is that not that they diagnose depression. They said it does not have serious side effects. I think we should resist the temptation of prescribing just because they do not have side effects, or it seems that they are tolerating this drug better. Coming to Susmita's point, there could be situations where you want to try something even though there is no evidence for it. But then that is purely empirical and case-to-case basis. There is some literature to suggest that repetitive behavior, compulsive behavior in some people with frontotemporal dementias, OC-like symptoms, may benefit from SSRIs. That too for not for not on a long-term basis. What is important is to handle motor restlessness and avoid getting lost. That is the most important intervention. We'll quickly go through the other things. I'm not discussing anything. Huntington's is different. Pharmacological management may be different. We had reported a 7-year follow-up of a progressive supranuclear palsy, which presented just like this case. Depressed, responded to depression, then became apathy predominant and pseudobulbar symptoms came on and did not have cholinergic deficiency. That was 2014 in Indian Journal of Geriatric Mental Health. So there are other things which have similar features. So remember this, rule out reversible causes, vascular cause, identify degenerative dementias, and then differentiate between 3 major causes or other rarer causes. Non-pharmacological, I think that is the difference of opinion, if I might want to express that in public here. The focus of management shall be non-pharmacological. And that is the first line, not for frontotemporal dementia. Every person with dementia deserves non-pharmacological interventions and usually benefit from non-pharmacological interventions, and they might be effective in reducing caregiver burden. So every pharmacotherapy will come in the background of non-pharmacological therapy. These are the 3 ingredients. Remember that most people across the globe in this country and most developing world has co-resident family members looking after patients. So we will be, these are the 3 things. I'm not going to discuss things in detail, but then help in management of symptoms. Non-pharmacological methods which are innovative has to be tried here. Tips in management can help. We will have to learn from relatives and literature regarding this. Most important thing is support. Imagine I have a relative who is less than 60 years or less than 65 years, fairly well-built, healthy, maybe a male at times. Then he has frontotemporal dementia. He has no insight, poor judgment. He has got dysfunctional frontal lobe, dysexecutive in nature, and then it can be a big problem. So there, it's very important that we support them in all ways we can. Remember, in the Western world, dementia care has become a public health issue, and caregivers are very, very important stakeholders and are listened to by the governments and politicians. I remember when way back in 2015, when Nick Clegg was the Deputy Prime Minister, during his election campaign, he was demanding that young onset dementia and the caregivers of people with young onset dementia should be given support from the National Health Service in the UK. So it can even become an election issue in countries where you have an aged population. Maybe Kerala is one such place. Please go through this module. This is very good. We have, this is available. Training caregivers, you could use this to some extent, and outreach services. So remember that we have to have printed information. This is something which we produced in Malayalam, but then Indian Association of Geriatric Mental Health will be translating this into English, and then probably all of you could develop adapted versions which can be useful. This has a chapter on how to manage behavioral symptoms, which can be of great help for management of dementia, frontotemporal dementia. This is my task. I'm sure you'll appreciate that IPS has a task force. We are working on developing a module for home-based dementia care. Of course, that is something which I'm sure we will look at in doing that. So thank you very much. I'm ready to take questions, but then I know that things are getting slightly prolonged. Thanks to Chairperson Nihal and Co-Chairperson. It was a pleasure talking to you and so many people listening. It was an opportunity for me to say what I wanted to say. So I think that's it. There are
Thank you very much.
very few alternatives for home-based dementia care. Home is one of those care, but then we must build spaces. I also support all efforts that if home-based care is not possible, we should have good places. I'm sure all of us, if you have developed dementia some point of your life, if nobody can look after us at home, we might want to be in a decent place and have a fairly decent life with dementia. So FTD can be very challenging. Thank you all once again.
Thank you, Shaji sir, for this extensive deliberation on a topic which actually really caregivers, more than patient, is more of a caregiver burden for the young dementias. And FTD is one of the factors where the young dementia is one of the major causes. So with this, I'll not take much time. We'll go to any questions if they're in the chat box. And Dr. Vishal is also there with us. So we'll go to chat box if any question is there, sir. Nihal, you can just go to the chat box and see whatever the important questions are there. We can discuss it.
Sure, sir. So before I take on the questions, Vishal, after your comments, please.
Ajay, Vishal sir wants to come.
So it was a really enlightening talk on difficult topic by Dr. Shaji sir. It's a gray area for us and needs not a lot of expertise to deal with such cases. I would like to make few comments on the topic approach to behavioral variant of frontotemporal dementia. The behavioral variant, which is most important, reflects degeneration primarily of the frontal rather than temporal lobes. Patients with behavioral variant show a broad decline in affect and behavior, but they retain visuospatial ability. For example, they can copy a picture but can't draw the picture out of memory. They do not lose their sense of direction even in new surroundings. It's a known fact that frontotemporal dementia is an abnormality in tau metabolism. It is linked with the mutant gene on chromosome 17, which codes for tau. With these, first of all, I would like to thank the organizers for giving this opportunity, and I feel privileged to share the platform with Mishra ji and Shaji sir.
Is there a need to respond to one or two questions?
Yes, sir.
Yes, sir.
Yeah, I want to take that question by Bhaskar Mukherjee. Dr. Bhaskar, it was very deliberate on my part to talk about DLB here. And I do not know whether in clinical practice, whether when we diagnose FTD, you have to consider the possibility of DLB as an important differential. That was the reason one. Number two, there are similarities and differences between DLB and FTD. So I don't agree with you. That is my concern, and it was my choice there. Sorry to say that.
Yes.
Yeah.
Because frontotemporal variant has got almost 4 variants, so the it mimic. It is very difficult to differentiate between the symptom profile in those cases.
Yeah,
so there's some overlap is there always.
Mishra ji, another thing is, see, frontotemporal dementias, number of different variants. And another thing is that in clinical practice, there are certain distinctions which we have to make for, management. So that way it is important. And this comparison is also important because generally LBD has a more progressive course, whereas frontotemporal has a much more slower progression. And social inappropriateness is the difference and hallmark. So I think there is this need for us. These are two kinds of dementias which I had seen in my clinical work for the last
Yeah.
20 years. So it's important that every clinician considers these three first when you are left, when you rule out reversible and vascular. That is the reason for that. So different types are there. We have seen absolutely mute people, that they are very rare. Progressive aphasias are extremely rare in clinical practice. So if Nihal can,
Yeah.
any
Nihal or Kashyapi, any questions are there? Just go through the
Yes.
chat box.
Yeah,
If
yeah,
any,
I'm also
any
seeing.
important questions.
Sir, kindly tell the treatment for behavioral variant FTD, patient with target symptoms, disinhibition, cruelty to animals, cleaning compulsions, overeating, mainly sweets.
I don't think there is any drug which will help. Only thing is, sometimes you will have to use antipsychotics, but then try any antipsychotic, especially olanzapine, might actually increase appetite. So there is a problem. Behavioral management could be tried. When I say behavioral management, we are not talking about behavioral modification in the sense which we understand. What we do, or what I advise everybody to do, is to have a partnership with the caregiver so that you can set limits to this behavior. Wandering is something which you have to keep in mind, and we must also say that we must inform most people around that this person could be lost, and if found, we should try to get this person back to the place.
Sir, the next question is, does SSRIs work even in disinhibited behavior in FTD?
As was rightly mentioned by the presenter, we have very limited pharmacological choices in frontotemporal dementia. So you ask me, if you have a behavioral symptom which is persistent and distressing, the only drug which I am ready to try first is an SSRI. It's not that we presume that a person with FTD will respond in the same manner like OCD or depression. It is one drug which had been historically tried in people with FTD and found and reported to be of use. So I would give a trial of SSRI. We do not know.
How wandering can be controlled in FTD?
I think one temptation would be, especially daytime wandering, you might want to use a drug. Neuroleptic sensitivity, though present, can happen in FTD, but it is much less frequent than dementia with Lewy bodies. So you could try small doses, but then many a time an accompanying person who is able to direct the person's movement will be of some help, and helpful relatives and neighbors might help. And allowing a person to have a schedule of activities where a lot of physical exertion is included is one way which is being tried in many places. For example, engagement in games, physical activities during daytime would probably reduce the need for wandering, restlessness.
Sir, any update on gene therapy?
No, I'm not. I must also acknowledge here that my understanding about all those so-called latest things are extremely poor, and I have no inclination to update that also, because most of the things are very far away. So at the moment, there could be things which are in the offing, but I'm not sure. I don't know is the answer.
We had one patient of diagnosed FTD who had severe cognitive loss along with apathy and severe psychomotor excitation. Was given quetiapine till 600 mg, but still did not show any response.
This is the usual thing. They might sleep better, and then I'm not pessimistic, but impression is that when things go on for some time, into the illness, restlessness comes down. When frailty and other problems cognitive symptoms become prominent in an FTD, that is when restlessness comes down. But short course of quetiapine-like thing could be tried, no harm. It is very difficult. We have had very tough patients who required institutionalization purely because of management reasons.
Sir, experience with memantine in FTD also does rivastigmine over donepezil in Alzheimer's disease AD?
I must be candid here. I am very clear that I am not going to try any cholinesterase inhibitor in frontotemporal dementias. If I am very definite that this is a frontotemporal dementia, the literature do not support. There may be occasional reports, but then when we give a cholinesterase inhibitor, there has to be a fundamental presumption that there is some kind of acetylcholine involvement there. There is little evidence. In fact, one PSP, which we reported in 2014, we have reported the usefulness of trihexyphenidyl to control Parkinsonism. And we postulated even that in PSP, the evidence for a pathophysiology where there is cholinesterase deficiency, that is not strong. So we did not have any worsening of cognitive symptoms. So it's a different kind of dementia, as I understand. I may be wrong.
How to manage severe psychomotor agitation in FTD?
I might suggest that a trial of sodium valproate or things like that might be. See, the moment you try and fail antipsychotic, then you know that it won't work. And falls are obviously a problem with many a neurodegenerative dementia. So then you are adding to the problem. But then I am also not sure whether there is sound evidence. I don't think there is no sound evidence. But then giving a trial of sodium valproate might, you might want to do that. Yes.
So the last question, are there any long-term stay facilities for patients with severe dementia?
Pardon? Oh, yes.
Long stay facilities.
No, see, there are few facilities in various parts of the country, but they are so few and so inadequate that there is no good facility. There has to be good facility, one, standalone dementia care centers, or two, along with psychiatry hospitals, where you can have a geriatric ward or a dementia ward. That's a long-term, or a respite care facility.
Sir, one last question, sir. SSRI under antipsychotic cover?
See, I can only say that the case presented by Susmita was a very challenging situation. You might want to try things, but then my only advice to people who try things, that just beware that you are trying things without much evidence. Number two, the placebo response in behavioral and psychological symptoms of dementia is something like 50%. For example, you try this combination which you think is useful because you think that there is a logic for you. Then 50% of the time, things could improve by itself. So it may not be due to your drug. Just because something improved, even in this case, which was presented by Susmita, it might be just that things improved by itself. It might not be due to the drug. So that is a problem which we have in challenging conditions without pharmacological treatment. That's all what I can say. Over to you, Nihal.
We got one more question now, sir. How frequently seizures, clinical or subclinical, are seen in FTD?
Subclinical?
And how frequently seizures, clinical or subclinical, seen in FTD?
Seizures.
Yes, sir.
Seizure in
Oh,
FTD.
yeah. I have not seen many. Only thing is antipsychotics can increase the risk of seizures.
Seizure, yes.
Seizures are much more frequently seen. Rare occasional seizures are more frequent with cerebrovascular kind of dementia than this. But then it can happen later. And they have a more vulnerable brain. For example, if you use drugs which reduce seizure threshold, it can have seizures. But then recurrent seizures are not really a problem. Movement disorder is something which can come on later on, both in frontotemporal dementia and in dementia with Lewy bodies. Unlike Alzheimer's disease. We have had
your choice of imaging study.
Dystonia of the body, torsion dystonia. Later on in frontotemporal dementia, we have had one like that. Yes.
So, what is your choice of imaging study to diagnose a frontotemporal dementias?
I think
MRI is the best option.
the best of my knowledge is an MRI, which will tell you, and in a good center where they can actually tell you whether there is such focal or a involvement of frontotemporal with no involvement or very limited involvement of parietal and other lobes. That is what will clinch the diagnosis.
That's it, sir. I think we can conclude this session. We have covered all the questions.
Sir.
Yes.
Susmita, yes.
Sir, I have one question regarding the placebo. Sir, I wanted to know that patient had been on medication previously also. There had been no placebo response there. And we started medication and the patient is responding for the last 1.5 years. So according to my knowledge, placebo response doesn't last for years. So,
no. Sorry. I thanks Susmita for me using that term rather loosely. When I said placebo response, I was referring to the kind of response which you have with placebo in a randomized controlled trial situation. Placebo response is not that someone is given a drug under that. See, placebo response by definition in a situation is that you are controlling for natural remission or things which happen with no contribution from the drug. So that is what I meant. It might this has happened to many of my patients. I start somebody on a certain drug and then they respond. But I was trying to say that 50% of the time that is not due to drugs. That is natural remission.
Even antimicrobials.
Yeah. No, let us not argue, Susmita. My point is that it could have been drug, but we do not know. That is the problem with single case study. When you have somebody responding, you think they are responding due to the pharmacological effects of the drug. You could be 100% right or 100% wrong.
So, any supplements useful?
No, I think good nutrition and other supplements, good. No harm in trying atomoxetine or whatever. But then decide when you will start and when you will stop if it does not work. If you work like Susmita, you feel free to continue that. No harm. Because you are treating a condition where there is no useful drug known. If you think it is useful, if the person thinks it is helpful, no harm in continuing. My point is that you may be 100% right or it may be something else.
But we are done with the questions, sir. So,
thank you.
So,
hope I was not rude, Susmita.
Sir,
thank you. No, I think it's just because there was aggression, it was purely academic.
Yes.
Thank you, Shaji sir. Thank you, K Mishra sir. Thank you, Susmita. Thank you, Vishal Akula sir, for accepting our request.
Thank you, sir.
Thank you very much. Thank you very much, Nihal, Kashyapi, and the
you,
young
Dr.
leaders, and
Thank you, sir.
Susmita and Saji and Vishal. It's really a good opportunity to discuss the important aspects.
Yes,
Thank
sir.
you very much. Thank you.
Yes, I hope to see you all at Ipsicon and Midsep, sir.
Thank you. Thank you.
Sure, sure. Thank you all for giving
Good
us.
night.
Good
Good
night.
night, sir. Good night.
Good night. Bye. Thank you, Shaji sir. Good night, sir. Thank
Good
you.
night,
Sir.
sir.
Good night. Good night.
Take care, sir. Please take care, sir.
Good night.
And take care.
Thank you, sir. Yeah.
Thank you, sir, for joining.
Thank
Thank
you.
you, sir.
Good night.
Apply, sir. So,
We can leave.
yeah, we can end the session. I'll stop the
Yeah,
recording.
end the session.